forum is uh, specially designed to empower, inspire, and engage our next generation of physicians, especially the future of internal medicine in Sri Lanka. And today we have actually designed a topic that is timely and essential, which is precision towards shape the future of the prescription of antibiotics in an era of antimicrobial resistant. I think this topic is very timely, and in the prescribing is not just safe prescribing is not just a concept; it is our responsibility as well. And I sincerely appreciate Professor Lakmal Fonseka for gracefully accepting our invitation for his actually pet topic, which will undoubtedly guide us towards, safe and smarter and more appropriate antibiotic prescription. And special thank to Dr. Sahan Mendes, who has taken the trouble to leading this and coordinating the Next Gen Forum along with the help of GETS team. And I think I should mention special thank to Dr. Ganga Gunasekar and Dr. Yusuf, who are our secretaries running smoothly behind the scenes and making sure that everything is happening at the right place and right time. So as well as the office SLCM office team and all our participants, thank you very much for spending your evening with us, and your presence and engagement is very essential to have a meaningful discussion today. And later on, I thought of sharing a Google link to you to get your idea about leadership and soft skill enhancing program that we are planning to launch later on. And please note that the CPD points also will be awarded for this. And again, thank you very much for patiently waiting for this, because we also had this problem, and please stay together and let's learn together, reflect together, and shape the future of internal medicine. Thank you very much.
Thank you, madam. Thank you. So, as we are going to start the webinar, I would like to give you some housekeeping messages. As Madam mentioned, so we will have a QR code displayed at the end of the webinar during the Q&A session. So during that time, you can scan the QR code and also fill the Google form linked to the QR code. You can apply for CPD points because this is a CPD accredited program, and also give you valuable feedback for our new future programs as well. And during the lecture, the participants will be muted throughout the webinar. So, but you can forward your questions mentioned in the Q&A box, which is in the Zoom platform. And at the end of the lecture, the questions from the audience will be taken for discussion. And also, you can forward your questions during the Q&A session. So in order to start the webinar, I would like to introduce our speaker today. It's my pleasure to introduce our speaker for this evening, Professor Lakmal Fonseka, MBBS, MD Medicine, MRCP UK, FRCP UK, DPhil Oxford. Professor Fonseca is a professor in medicine at the Faculty of Medicine, University of Ruhuna, and is a distinguished clinician and academic with an outstanding record of academic excellence and research. He graduated from the Faculty of Medicine, University of Ruhuna with exceptional academic achievements, obtaining first-class honors at the final MBBS exams with distinctions in anatomy, physiology, biochemistry, microbiology, parasitology, pathology, and pharmacology, as well as distinctions in medicine, surgery, and pediatrics. In recognition of this remarkable performance, Professor Fonseca was awarded gold medals in medicine, pediatrics, surgery, and physiology. He also had postgraduate accomplishments which are equally outstanding. At the MD in Medicine Part 2 exams in April 2017, he was ranked first and received the prestigious Dr. John Stokes Gold Medal Dr. Nanda Amarasekara Award for Best Performance, and the Ceylon College of Physicians Award for Excellence in MD Medicine. He completed his Doctor of Philosophy in Infectious Diseases at the University of Oxford, the United Kingdom, and his research interests are focused on infectious diseases, neglected tropical diseases, and global health. We are truly privileged to have Professor Lakmal Fonseka with us today, and we warmly welcome him to share his insights. Today at the NextGen Forum, Professor Fonseca will speak to us on precision stewardship, the future of the prescription of antibiotics. So I cordially invite Professor Lakmal Fonseca to deliver his lecture. Over to you.
Yeah, thank you, Sohan. Can you hear me? And you
Yes,
can
we
see the
can hear
slides
you
as well,
and we can
hopefully.
see the slides. Yes.
Yeah, thank you so much. Right. So thank you, Sri Lankan College of Internal Medicine, for inviting me to deliver this talk today. So let's dive in without further waiting. So today we are going to talk about antibiotic stewardship and how to be precise and how to optimize your stewardship skills. That's what we are going to discuss today. Yeah. So antibiotic prescription is an art. So AMR is a very global threat, and it's about time we should discuss about it. And in the future, we'll have more infections. There'll be more resistance. There'll be infections with higher severity, and there'll be higher mortality. And we'll be having a momentous amount of problems in the future. It's going to get worse if we don't act fast. So a bit of a word about antibiotic stewards. So antibiotic steward is a rational prescriber. So we often think that antibiotic stewards are the ones who always cut down antibiotics, stop antibiotics, and give a shorter duration of antibiotics. But antibiotic stewards are ones who knows to hit hard, like Glenn Maxwell over there. So they know how to resuscitate patients, how to broaden spectrum antibiotic, and when to exactly deliver and give that element of surprise for those bacteria and be artist in killing those bacteria. And they are also good at faster source control, faster in achieving infection control. And also, these people are precise in their diagnosis as well, how to differentiate viral or bacterial, how to see whether it is non-infectious, and carefully assess the source of infection to see whether there is a pyelonephritis, cellulitis, pneumonia, etc. And also, the antibiotic stewards are capable in optimizing or de-escalating antibiotics, when to stop and when to lower the spectrum, and when to switch from IV antibiotic for oral antibiotic, and hopefully send the patient home early. So an antibiotic steward should be equipped with all these three parameters. And let's learn how we can have few skills by discussing through some case scenarios. Before that, we had to understand there are two dimensions for this prescription. What about the future of Sri Lanka and future of the world? Because we are lagging behind maybe around 20 to 30 years when you look at the other part of the world. And what is the future of the world beholds? I'll discuss about this at the latter part of the lecture. So regarding the facets of optimizing stewardship, we have to have clinical precision, diagnostic precision, and laboratory precision. Clinical precision is your bedside skills, that you're examining history, examination skills, and identify the clinical recovery or clinical worsening. And then diagnostic precision, tallied up with your clinical diagnosis. Do we have enough tools to diagnose the infection? And laboratory precision comes, you're liaising with the microbiology team and whether we have the cultures and all the data to back it up. So let's dive in with the case. A 55-year-old male admitted to the hospital with low-grade fever, chills, lower abdominal pain. His ultrasound revealed normal findings. UFR is positive and urine culture is pending. So you could always think about what is the infection that we are treating here. And how would you treat this patient? I'll give you a few seconds to have a think about it. So answer is giving cotrimoxazole for this patient. So I'll explain why. So regarding how to load your precision skills, we have to identify whether this patient is having an upper urinary tract infection or lower urinary tract infection. Lower urinary tract infection, whether it is an afebrile lower UTI or a febrile lower UTI, because the treatment varies according to that. Also think about whether this patient can harbor any resistant organisms such as ESBL. Look at the renal impairment, look at the creatinine, whether we have to dose change our antibiotics. And also then consider the access group of antibiotics according to the AWARE classification. I give you a briefing about what is AWARE classification, and we are using access group of antibiotics for that. So this is an antibiotic protocol that our college has produced over the last year. So you could see here in a lower UTI, a patient who is having fever, suprapubic pain, lower urinary symptoms. So we are considering this as cystitis or urethritis. And if it is an uncomplicated infection, we usually consider afebrile patients are having uncomplicated lower UTI. Those patients should receive nitrofurantoin, cephalexin, or a stat dose of gentamicin. People who are having febrile UTIs are called as complicated lower UTIs. So these people should receive, in an order of preference, cotrimoxazole, norfloxacin, pivmesilinair, or coamoxiclav. So those are the options that they have. So going back to the earlier slide, we had to first identify this the lower UTI, and this is a febrile lower UTI. And this patient did not have any specific risk factors for ESBL, and we are using an access group of antibiotic. So this is the AWARE classification. It has 3 groups: access, watch, and reserve group of antibiotics. So if you look at this access group of antibiotics, these are the ones we should always try to use as first line for our infections, especially in the outpatient department of hospitals, because these are the ones who cause the least amount of antimicrobial resistance. When you go to the right side, looking at watch group and reserve group for antibiotics, we are inducing more and more antimicrobial resistance. And these access group of antibiotics over here are low cost, but they are very focused antibiotics and are best when you use it properly to the appropriate infection. So here the answer is cotrimoxazole because it's a febrile lower UTI. And nitrofurantoin is usually used for an afebrile lower UTI. And gentamicin also can be used in both circumstances, but we can use IV gentamicin as a stat dose for lower urinary tract infections. Going into the next case, a 70-year-old female treated for pyelonephritis with IV coamoxiclav. And on day of admission and on 24 hours, the parameters are given here. So after 24 hours, the microbiology lab calls you and tells that there are gram-negative rods in the blood culture. So in the admission, the clinical parameters, the patient is ill, vitals are relatively all right. The white cell counts are 18,000, CRP is 120, and fever is present, and you start on IV coamoxiclav on this patient. But 24 hours after, we are seeing that the patient has a slight improvement, but not very significant. But vitals are relatively all right. And the WBC is 30. It has reduced, but you can see a significant rise in the CRP. And the fever is still present. So what will you do now? So the answer is continuing the same. So here the main problem is you can see the patient's clinical improvement is like very subtle, But you can see the CRP is increasing. The white cell count is it's going other way around, isn't it? So it's very tricky how to decide on it. Then at these stages, you have to rely on the clinical status of the patient. The patient's vitals are okay. So we have more time. If you want to escalate antibiotics, we have more time, right? And there's a doubt that patient is getting better. So it's on the right side, good side of things. And also I should explain the trajectory of the CRP and white cell counts here. This is an important parameter that we see on daily basis. So the red graph is the CRP. You can see the trajectory of rise in CRP is extremely high when there's an infection. There's a rapid rise of CRP, and when antibiotics are administered over here, then there's a reduction of the CRP level. But of course, because of the velocity of change of CRP is very high, it takes a while for it to come down. But when you talk about the velocity of change of the WBC, it is low. So when you give an antibiotic, it has the chance for it to quickly reduce with the effective antibiotics. So here we can see, although the CRP is rising and downtrending, after 24 hours, you could see the value is here. It still increased from the admission value of like 120. It has increased to 200, but you could still that the CRP is downtrending here, right? So it is still responding. Although you visually see an increase, it is still responding. You could get a clue from the reduction of the WBC here. As you can see on admission, the WBC around 18,000. Then you could see the WBC has reduced to like 12,000 after the 24-hour time point. So this is called as the lag of the CRP. So if the patient is clinically getting better and the WBC is reducing, you can actually wait for some time and repeat the CRP on the next day to see whether it is reducing. How can we be more precise now? This is an elderly male who is having elderly males or elderly anyone who's elderly is having a higher ESBL risk. So, and any comorbidities, this patient did not have any. No previous history of hospitalization, not on a catheter, immunosuppressants, but not there. So there was not much of risks of ESBL here. But when you think about the clinical severity, this is a moderate pyelonephritis, but the vitals are stable. However, the patient ill and febrile. So which means that we have time to, even if we are not giving the right antibiotic therapy, we have time to escalate antibiotic to a better if the patient is worsening. And also note the urinary excretion of antibiotics. This is an important concept. If you think about the beta-lactam antibiotics here, you could see the peak concentrations of antibiotics here. I'm showing it from the cursor. But when you think about the renal excretion, usually the renal excretion is around like 50 to 75% in beta-lactams. But when you look at urinary concentrations of these antibiotics, is extremely high, nearly more than 10 to 100 times higher than the peak serum concentration. So remember, when you give an antibiotic orally, and if you are tackling a urinary tract infection, you are sure that you are going to get really high concentrations of that antibiotic in the urine. So the plate cannot mimic that. It's difficult because you are having really high concentrations, and sometimes even though the plate says resistant, and they can be very sensitive because you are going way above the minimum inhibitory concentration of that antibiotic by giving an antibiotic which is excreted in urine mostly. And look at aminoglycosides here. So if you look at here, the peak serum concentration is around this level, but when you look at renal excretion of the unchanged, it's very high. It's nearly 100% concentrated in the kidneys. So these drugs are amazing for urinary tract infections because some beta-lactams, they get concentrated in the urine in high levels. And when you talk about the aminoglycoside, they are 100% excreted in the kidneys. So coming back to the case. So this case, after some time, the culture revealed an organism which is Klebsiella pneumoniae. and the system flagged that it's a ESBL producer. And the patient is currently on comoxiclav, and the ward team has given a stat dose of Gent, and the patient is doing well. But the cultures now say it is resistant to comoxiclav, which is the antibiotic that we are giving, and it's sensitive to nitrofurantoin, cotrimoxazole, ciprofloxacin, and meropenem. Remember, there's a bacteremia here, and there's the clinical, actually clinical is patient getting better, but the culture is showing it is resistant. What would you do now? So there are two options here. One person would continue the same, right, which is a brave option. And sometimes a person would continue the co-trim as well, you know. So there are several options that we can take. So I will rationalize why. So first thing is, we are giving one added advantage here is the urinary concentration of comoxiclav. So we are having really high concentrations in the kidneys. So that is the reason that it's working, although the culture is saying that it is resistant. So we are in good hands. And the patient, when you look at 48 hours time point, the WBC is reducing and the CRP is reducing. So we could think that we could continue IV antibiotics like comoxiclav for the expected duration for a bacteremia, 7 to 10 days. And we can switch to orals if the patient is getting better, and IV comoxiclav to oral comoxiclav. I mean, I don't see any problem there. And one person would say, okay, let's switch to something, if the patient is getting better, let's switch to oral antibiotics from comoxiclav to a cotrimoxazole. So it has a good urinary penetration and the patient is responding, and you could clearly see that it is sensitive in the urine culture, right? And another person would be escalating to meropenem because that's the gold standard drug for an ESBL infection. So let's dive into some guidelines here. So what we did there is I think the patient is responding, and whether we could continue the same under monitoring. And the real catch here is if you have a patient who is at high risk of having a worse infection, a frail person, having previous history of UTIs, patient with CKD who can easily get worse and get in a critical situation. So those patients, you can escalate to piperazine, tazobactam, or meropenem in that case, right? But if it is a young, healthy person who does not have comorbidities, you can anyway stick to your comoxiclav as well. So when choices about an ESBL, when you talk about the guidelines of IDSA and ESCMID, so there are things to learn from this. So when you talk about the ESBL infections, let's talk about the lower UTIs. When you talk about the lower UTIs, nitrofurantoin, cotrimoxazole are the first line, the green ones are the first line antibiotics. If you're giving IV, cefepime and also piperazine, tazobactam are the first choices. And remember, second line ones are comoxiclav and fosfomycin or a stat dose of gentamicin. And remember, carbapenems are the third lines here because carbapenems are precious drugs, broad spectrum, and we should reserve it for like severe critical infections, and let's not use it as the first line for like mildest infections. When you look at the upper UTIs and also complicated UTIs, they have mentioned in carbapenems as the first line. So, which is to say meropenem, imipenem, and ertapenem, anyone can be used. And also we can use cotrimoxazole, quinolones as step downs. Non-UTIs, intra-abdominal infections, the carbapenems are the first line, and cotrimoxazole, quinolones are the second line. So mind you, these guidelines are coming right from the Merino trial, which they have proven that the meropenem is, they have proven that meropenem actually has a better rates of mortality or recovery when you compare it to piperazine and tazobactam. So the first line drug for like ESBL, especially if a patient is critical ill, is meropenem. And let's look at the SMIT. They have laid down guidelines according to the whether it's a bloodstream infection or not. BSI means a bacteremia. So if there's a bacteremia, a severe infections, the carbapenems are the first line, but not ertapenem. And if it is a BS bloodstream infection, which is non-severe, again, all the carbapenems are preferred. If it is not a bloodstream infection, we can use the other agents such as piperacillin tazobactam and also coamoxiclav and the quinolones. So those are options here. And let's move on to the next case. So a 67-year-old female, a retired sister from a surgical, is having a recurrent UTI, is having uncontrolled diabetes for 5 years. She had nearly monthly doctor encounters or admissions. And over the last year, she had 5 admissions with lower UTIs and 3 admissions with pyelonephritis, 1 admission with septic shock. Basically, she was really tired. She was basically going in and out of the hospital. Most of the days in the year, she was in the hospital. So what can we do next? So I would give 2 answers here. We can try to think about giving a nitrofurantoin prophylaxis for this patient. And also we can use each time admit with outpatient therapy gentamicin. Let's discuss more about it, why we can use this. So how to get these precision skills on board? So we have to think about the risk factors. Is a healthcare worker. And we have encountered ESBL infection possibly. A repeated hospitalization, recent hospitalization within 90 days. So all these risk factors suggest that this could be a likely ESBL. And especially the patient is having uncontrolled diabetes, which increases the risk of ESBL. So then we have to tighten the glycemic control for better infection control, talk about voiding habits, talk about stopping dehydration, imaging to see whether there's a structural abnormalities, see whether there's a cystocele or vaginal prolapse, and any post-voidal residual volumes, attend to those, and reassess whether all these admissions are infections. Sometimes we inadvertently treat non-infectious causes as infections, especially in elderly females when they have dysuria, which can be a post-menopausal sort of symptom. So assess whether this pyuria is really significant, more than 10 to 15 pus cells, otherwise it's considered normal, coupled with symptoms of a UTI. So and think about the treatment durations. If a lower UTI, it's 3 days, 3 to 5 days, and upper UTI is 7 days. Yeah. So what can we do here? We have to educate this patient to catch these UTIs very early rather than waiting until it develops to pyelonephritis or a septic shock. Catch them when they are lower UTIs and treat the clinical syndrome with evidence of UFR and urine cultures. Afebrile lower UTIs, you can try nitrofurantoin. Febrile lower UTIs, you can try Cotrim. And sometimes you can ambulate these patients who are having pyelonephritis with an expert guidance. And if it is severe, of course, start your meropenem. So by doing this, we have successfully reduced her admissions, but she used to still have recurrent UTIs. We couldn't possibly stop it. So then we thought of introducing prophylaxis for her. So main principle of introducing prophylaxis, you treat a UTI fully and you repeat a culture in about 1 or 2 weeks, see whether the culture is becoming negative, and then you introduce your prophylactic antibiotics. Before, if you have partially treated the urinary tract infection, you are still having the bacteria at high levels, and you are giving a lower dose of antibiotics because it is a prophylactic dose. Then the prophylaxis will not be effective. And sometimes you can use rotation prophylaxis to save antibiotics, because if you give longer, you are getting more and more resistance to prophylactic antibiotic. Right. So with prophylaxis, we reduce the UTIs to 5 per year. So she had only 5 infections per year the next year. So what can we do further? Still, do you have to admit this patient to give meropenem? We did another strategy here. So we kept the patient on urinary prophylaxis, educate the patient to identify the UTIs early, And if there is more pus cells, send the culture, and we give outpatient IV gentamicin or amikacin, a single dose for the patient. So because we know that the gentamicin, an access group antibiotic, we should use that, less induction of resistance, and it has a concentration dependent kill. The higher concentration you kill more and more bacteria, and it concentrates in the urine tract like 100%, and it has a post-antibiotic effect. Although we are giving single dose, it keeps on acting for about another day. And so by this way, we saved a lot of carbapenem for the hospital and for the country, and we kept the patient out of the hospital, and the patient was happy with the better quality of life. So some stewardship tips, there are drugs called oral pivmecylin, which are narrow-spectrum ESBL cover antibiotics, which can be used if your Cotrim and nitro cannot be used in CKD. And also in other countries, they have a drug called IV temocillin. So that is a narrow-spectrum beta-lactam antibiotic, which has a great ESBL cover, and it is carbapenem sparing. Remember, ladies and gentlemen, carbapenem is a great drug, but if we are going to the future saving carbapenems, we should be mindful about other options that we can use in infections, and that has a carbapenem sparing effect. So case 4, so we came across another man from Sweden. He had a history of kidney stone disease, admitted with bilateral ureteric obstruction with AKI. He had no fever, inflammatory markers are normal, but he underwent a bilateral ureteral rhinoscopy laser therapy. And when they are stenting, they identified the infected system draining pus, which is a collection in the pelvis of the kidney. And the bilateral stents were inserted, and post-procedure, the patient went into sepsis. And the cultures revealed E. coli resistant to all antibiotics. So what can we do now? We are helpless, as all antibiotics are showing it's resistant. So what we did here is to continue meropenem and gentamicin, and let's talk about what we can do here. So loading the precision. So this patient is a resident from Sweden. So it's unlikely. Sweden is a country who has very least amount of ESBL or MRSA. It's very, very unlikely for this patient to have a resistant organism. But he has a history of complex recurrent pyelonephritis, repeated hospitalization, and last 3 months also he has received broad spectrum antibiotics, was given meropenem. So because of that, we have to suspect resistance organism, ESBL, or maybe resistant to meropenem, because he has received many doses of meropenem before. And also we have to identify the ureteric stone is a critical nidus harboring infections. It allows the bacteria to thrive and get trapped in the stagnant urine. And some stone like staghorn harbor protease organisms. And sometimes you can have obstructions, raising pressure in the kidney, and they easily have bacteremia because the bacteria can spill into the blood very easily because of the obstruction. And also the patient can have acute kidney injury, so we have to alter the dosing. And are we suspecting a carbapenemase producer? So if the AMR gets worse in Sri Lanka, so we are going to face the huge problem of not ESBS and MRSA, but we have to have another problem, carbapenemase producers. They are present in Sri Lanka, and it is rising at a rampant level. So what is this carbapenemase producers? So carbapenem antibiotics are meropenem, imipenem, or ertapenem. So if somebody is producing enzymes to cut off these carbapenems, those are called carbapenemase producing organisms. So it can be Enterobacteriaceae, the typical gram-negative bugs, the Pseudomonas, and also Acinetobacter baumannii. So these organisms can produce carbapenemases and cut the carbapenem antibiotics, making it less effective. So the main problem with carbapenemases they are dreaded because they are transmissible. The organisms can easily acquire these carbapenemases unpredictably, and it can act as a nosocomial pathogens, and they can have outbreaks in hospitals, especially when it comes to Pseudomonas, Acinetobacter, and many Enterobacteriaceae. So there are types of how do we know whether it is carbapenemase producing organism? There are some microbiological clues that we can take. There are several types of carbapenemase, types such as MBL, OX48, and KPC. These are the three, common types that you see as carbapenemases. So MBL, how do you identify MBLs? And they are resistant to all beta-lactams except aztreonam. And so aminoglycoside, fluoroquinolones are everything resistant, but they can be susceptible to polymyxins and also aztreonam. So we can, from looking at this, we can get a clue by looking at the aztreonam sensitivity, whether it is an MBL or not. And what about OX48? So they weakly hydrolyze the carbapenems, but does not hydrolyze extended spectrum cephalosporins. So although the culture reports say it's resistant to ertapenem, it can be susceptible. The cephtaxidium will be susceptible, sensitive in certain cases, and they might have susceptible or intermediate susceptibility for imipenem or meropenem. The key is ertapenem resistance, and they might have intermediate or sensitive to other carbapenems, and they can be susceptible to ceftazidime. The KPC, how do you identify this? Is it resistance to everything? You say carbapenem, cephalosporins, aztreonam, so everything is resistance. But mind you, these carbapenemase producing organisms should not be treated on just suspicion. Because your antibiotics are not working in all the patients, right? Do not suspect carbapenemase producers in all these patients. It should be guided by cultures, and we should detect and treat. There are many ways that you can, identify those. You have to liaise with the microbiology team. They are the experts on this regard, and they are the ones who are having best knowledge, managing these patients better. And so best to see whether we can do a rapid molecular test, a PCR. To my knowledge, I think there's a respiratory biofire which identifies these organisms, whether it is MBL, OX48, or KPC. Otherwise, I'm not sure whether it is frequently available in Sri Lanka. So why should we identify KPC, OX48, and MBL? Is your antibiotic choice is going to differ. So if it is KPC or OX48, you are thinking about more on like ceftazidime avibactam based therapy. But of course, you could see for the lower UTIs and upper UTIs, we can use high-dose meropenem and gentamicin. So we used high-dose meropenem and gentamicin because of the synergy. It's because they work together, and also the concentration depending killing properties that the gentamicin has. So it can go way beyond the MIC, which is laid down in the culture plate. And the other ECMIC guidelines also the same. The ceftazidime avibactam is the base of treatment for KPC and OX48, and for the MBLs, the main one that is used is aztreonam or ceftazidime avibactam. So although as I mentioned before, sometimes the MBLs will show that the aztreonam is sensitive and all the antibiotics are resistant, but you don't use aztreonam alone, and you have to always pair that up with ceftazidime avibactam. So these are like general knowledge points, for us to be aware about carbapenemases, right? So because in the future, we'll have a lot of those. If you have some background knowledge, you can liaise with the experts, the microbiologist, and do your best for the patient that you have in front of you. So what do you do? The case number 4, meropenem and gentamicin for 7 days. And then he recovered well, and antibiotics were stopped after 7 days, and the patient was discharged home. But we were unable to confirm whether it is carbapenemase produced or an MDR organism because we did not have the cultures to do that. Okay, so then what is important is the striking the prescription balance. This is a vital concept that we had to understand. I mean, we have meropenem, we have vancomycin. So why might ask, why can't we use meropenem and vancomycin for all these infections, right? So basically, as this cricket player, that you are going to face a hit wicket if you try to hit hard with meropenem every time. So it will circle boomerang back to you, and the run out opportunity. So you should be able to have a clinical precision as a steward to identify bacterial and viral, and also prioritize the infections and give the best possible antibiotic, prioritize your differential diagnosis. So I'm moving to the next section, which is like going to finish very quickly. So this is about what the world has as tools for antibiotic precision. So current state is we are giving empiric therapy, and we are waiting until the culture comes to you 2 days or 3 days. And if you're lucky, you're going to get a call in 48 hours. Sometimes in a busy day, the microbiology labs will be burdened with all the cultures, and you might get it further delayed as well. So what about the future? The precision assured is getting the right drug, right dose, right duration, right patient, assessing all this, and philosophically moving from a population-based guideline to an individualized and a data-driven therapy. So what are the tools that the other countries has? Oh, sorry. What are the tools that Sri Lanka has, first of all? So what we have, the best thing that happened to Sri Lanka is starting of the antibiotic stewardship committees in Sri Lanka. In 2024, the Sri Lankan College of Microbiologists, with the leadership of Dr. Malika Karunaratne, they together with the Ministry of Health, with their leadership, they started introducing antibiotic stewardship, giving leadership, being accountable for AMR, and sharing their expertise and trying to mitigate AMR by managing the infections better. But still, there are a lot of loopholes in this system. Difficult to monitor the antibiotic usage. Very difficult to surveillance the antibiotic resistance properly in a national scale. Stewardship rounds should be introduced, and how can we be collaborative with other physicians or clinicians or microbiologists working together to a common goal. These are things that we should learn in the future to fight AMR. But what about the other countries? They have these expensive but state-of-the-art equipments. So they have rapid diagnosis. They can sense MEC-A to identify MRSA. They can do a PCR, and 4 to 6 hours you have MEC-A positive and you're suspecting MRSA. VAN-A for VREs and carbapenem-based producers. You have like your OX48, the MBL PCRs, and lateral flow test for like ESBL. So other countries have rapid diagnosis. Other ones that are available in other countries are MALDI-TOF. This is mass spectrometry where it's interesting how it works. So there's a laser, and so these wells are having bacteria. So these lasers crush these bacteria and they reduce all these proteins, and they are going in this charged grid. And when they hit this detector, it gives rise to these peaks, each corresponding to a certain protein. From the protein pattern, you could identify the bacterial organism. Whether this is Staph aureus, you could see in 4 hours when you flag a blood culture being positive. After 4 hours, you could say Staph aureus, but you still can't say whether it is sensitive or resistant. Those are difficult to say. But in the future, they are going to make antimicrobial susceptibility phenotypes into this system as well. And precision at the genomic level is one thing that is up in the horizon. So we can do the NGS, look at the metagenomics and sequencing of all DNA, and look at what is the bacteria, what is the growth of them, slow growing, fast growing, what are the resistant genes that the bacteria is having, we can all see from the NGS. And the whole genome sequencing is also, you can look at the bacterial genetic code. And this is an interesting instrument, which is again a rapid diagnosis. This is the instrument used by Oxford Nanopore. This device is able to sequence a sample of saliva or sputum and give rise to a diagnosis of whether you are having a respiratory virus or a bacteria. So this is the Oxford Nanopore Technologies ship, the NASA used these DNA sequences in space to identify whether they are having an infection and to monitor their microbes and health. So this was actually done. This is not a fairy tale, it has been done. So this is the future that beholds. And there is something called targeted NGS. Again, the Oxford Nanopore. They have especially used for tuberculosis. They have this platform of sequencing which works over like 12 hours. So if you know this gene, RPOB gene, that is the gene that is used for GeneXpert in TB. So if the gene RPOB gene is positive, the GeneXpert is positive, which means to say is resistant to rifampicin. So this is how the GeneXpert test is created, by using this gene as a reference to the rifampicin sensitivity. So we don't have to wait until the culture comes up showing the rifampicin resistant. You can detect RPOB gene and say it is resistant. So same happens to like CAT-G and inhibin A. So that suggests that there's I think isoniazid resistance, and gyrase A and B will suggest that there's a quinolone resistance. So if a TB organism is positive somewhere, if you can run the targeted NGS, you could diagnose the TB organism and find out whether the antibiotics are sensitive and resistant as well in the same time. Within 12 hours, you would know whether you have a TB organism and what are the antibiotics which are sensitive and resistant real time. So isn't it amazing if we have that for all the gram-negative bacteria that we have nowadays? And also we did some publications on this recently as well, looking at the host gene response signature. So when you look at the host, the human, if I am having an infection, if you look at my genetic signature, by looking at it, you could see whether I am fighting a bacterial infection or a viral infection. So by analyzing the genetic signature of the host, the human, you could say whether it's a viral or bacterial. And we have used this model. This is an instrument called Biomeme, called as Franklin. And that instrument can tell whether you are fighting a virus or bacteria and the turnaround time in 80 minutes. If you load the sample in 80 minutes, it will say it's a viral or bacterial infection. So you could guide your antibiotic therapy, whether to give or not to give antibiotics. And in the future, there will be more personalized dosing regimes. There are things called model-informed precision dosing. So the software at the bedside will tell you with the weight, renal functions, albumin, and the patient's characteristics, and it will give the exact dosing that you should use for kill a certain bacteria without giving toxicity. And therapeutic drug monitoring, like that you have sensors to identify your blood glucose level. There will be sensors in future to identify the antibiotic levels in your body. And also we can use AI, intelligent, artificial intelligence support tools to look at models that analyzes the hospital data, patient characteristics, and you crunch those data into one platform and give the best antibiotic that you can give for a patient. And also in other countries, they have clinical decision support systems, like give a nudge for the doctor saying, okay, the culture has come up, is sensitive to cormoxiclav. Please de-escalate to cormoxiclav. Isn't it great if you have this kind of a system in Sri Lanka? So what is the future of antibiotic prescription in Sri Lanka? Is treating infections rationally with better clinical and diagnostic precision without fueling antimicrobial resistance. We have to save patients, but don't let it boomerangs back with antimicrobial resistance. So let's use antibiotics rationally, and all of us should be working together for that. Thank you.
Thank you very much, Professor Lakmal. So I think now it's time for a Q&A session where we have one question in the chat I can see. So the audience, you can forward your questions through the chat box so we can take them for discussion. So one question is regarding this. What could we do for bioma if it doesn't settle after drainage?
Sorry, Sahan, can you tell me again what?
The question is, what could we do for bioma if it doesn't settle after drainage?
What do you mean by
It is
bioma?
not, yeah.
I'm not sure what it is.
I think Dr. Guruparan, if you can further elaborate the question, you can mention it in the chat.
So the source control is very important until he,
Antibioma,
the
maybe
question.
somebody, I don't.
I have heard of that concept of antibiome, but I'm not sure what it is, So if you have an abscess in a patient, you have to try, and get source control as fast as possible, Attend to it quickly, and sometimes you might have to drain it like multiple times. But when you have a, big cavity, you can't expect for it to shrink like, because there's a, vacuum or the potential area. So you won't see it's like disappearing. So in which case, you have to sometimes guide it by the duration, rough duration. So if there's sometimes abscess, you might have to give like 2 to 4 weeks or 2 to 6 weeks of antibiotics. So you have to sometimes give with the duration, give the due respect by giving a longer duration if there's abscess that you cannot drain properly. So if you attempt to drain multiple times, if you empty it, you can give a shorter duration of antibiotic. But imagine if it is a intra-abdominal abscess that you cannot drain. So in that case, you will have to give a longer antibiotics.
In the meantime, I have shared the Google, the QR code for Google link. The participants can scan the QR code and fill the Google form for the CPD certificate. And I think there's another, yeah, it's not a question, I think, yeah. Yeah, this is a question. You mentioned about cyclical antibiotic prophylaxis. Can you kindly elaborate? We have a problem at times as some of the initial cultures are negative to all available oral antibiotics.
So which means the culture is resistant to all negative means resistant to all antibiotics, isn't it? Yeah, possibly that.
Yeah.
So if you have a patient who is, or you don't have any oral options, right? So then you are in trouble basically. So you have to give your IV. So, these are the situations that you have to seek expert, guidance, because in certain instances, depending on the patient, you can use, drugs that are highly concentrated in the urine, right? It can still be effective. So you have to basically tie up with your experts on this and individualize the treatment depending on the risk factors of the patient, right? Structural problems, and what are the, considering all that together, you have to decide. It does not mean that you cannot use any urinary prophylaxis, but it's challenging. You have to consider many factors there. Culture resistant play, first you have to identify whether it is a legitimate culture. You can repeat the cultures and see whether you get the same results, and again, everything is negative. You can start with IV, giving shorter durations. As I mentioned before, if it is a lower UTI, you can give a shorter duration, 3-day course of antibiotic, even if it is a, ESBL, and shorter the duration, and then moving on to like, you can use like sat dose of gens, as I mentioned before, as we in our patient. Then also think about the, oral antibiotic options as well. But I know it's not reassuring when you have resistant culture, but there are ways that you can use it. Sahan, can I pick a question from here? Is that all right?
Yes,
So
I
it's an
think there's another
interesting question
question.
because
Yeah.
Subatma has mentioned, I don't know whether it is Subatma that I know well. So he works in the hemato-oncology unit. Most of our patients are neutropenic. They're all on intensive chemotherapy, reduce their immunity significantly in these patients. When we suspect severe infection, can we wait? I'm hearing myself again. Can we straight away start treatment with carbapenems? So being in I have done antibiotic stewardship in hemato-oncology, like bone marrow transplant unit. So it is the toughest place that you can practice antibiotic stewardship, right? Because these patients, sometimes if they are having bone marrow transplant, they will have zero white cells, and they will have, you name, all the viruses and bacteria will become positive in them because they cannot mount an immune response. So these kind of patients, I think you to save, and as there is no inflammation, they can get worse really quickly, and they can easily die, and they can have fungal infections, PCP, MRSA, all the infections they can have. These are the toughest, infections to treat. Very difficult for antibiotics to work there, basically. So I think it's very fair to start with carbapenems, thinking that Sri Lanka has a lot of risk factors for ESBL, and sometimes if the patient is ill, you have a carbapenem. We start on vancomycin as well, MRSA cover, and also you might have to give the antifungal covers as well, and doing a CT and identify the focuses, having an MDT, lies with all the experts and mycologists, microbiologists, physicians, hemato-oncologists, everything getting together. So these any other questions that comes to you, sir?
Yes, I think there are. Which antibiotics are safe in pregnancy for urinary tract infection? Can you hear me?
Yeah, I can hear you now.
Yeah. One question is on which antibiotics are safe in pregnancy for UTI?
Yeah, so pregnant UTIs, you have to treat it. You have definitely send cultures and guide your, antibiotic therapy aligning with the urine cultures that you have. So cephalexin is the one that we can easily use in the pregnancy. So coamoxiclav has its own problems, because if you are treating very near the latter part of the pregnancy, there might be like fetal the neonatal necrotizing enterocolitis that can happen in the neonates. So you have to be very mindful. And nitrofurantoin will cause some hemolysis in the neonates in the latter part of the period, right? So the best antibiotic that you can use empirically is cephalexin in the pregnancy.
Thank you very much. So there's another question. So do we need to consider both CRP and WBC patterns for antibiotics? Do we need to wait for 48 hours to decide on escalation?
Uh, Consider both. Yeah, I mean, yes and no sometimes, you know. So first you have to, so there are, when you are deciding on escalation or de-escalation, you are looking at several factors. One thing is the clinical situation, status of the patient. When the patient's fever is present, whether it is reducing or persisting, how is the patient clinically looking ill, looking well, and how are the vital parameters? Are they stabilizing the oxygen level? If they're cellular, is the skin wrinkling? So initial 24 hours, 40 hours, those findings can be very subtle. But as a clinician, as you have seen the patient yesterday, you are the best person to see whether the patient is responding to your antibiotic or not. But yeah, the clues might be very subtle after 24 hours. But this is the biggest clue or the reassurance that gives you to see whether you are on the right track or not, isn't it? And this can be, their CRP and white cell counts are supportive things to guide your antibiotics. In the earlier 24 hours, as I said, because sometimes the WBC can reduce, but the CRP can be still rising due to this CRP lag. And the other question is, do we need to wait 40 years to also decide on escalation? So it all depends on your clinical status. If you feel that the patient is getting worse, right? If their inflammatory markers is not doing great, it's worsening, and the patient is going into shock, patient is becoming ill, don't wait. Just start on the best possible broad spectrum antibiotic to give at that time, because your main goal is to save the patient at that time. So escalate your antibiotics if you feel that the patient is getting better. But what I'm saying is your clinical precision skills we can improve by bedside frequent assessment of the patient, and also guided by the CRP and WBC counts. And you can get a fair idea whether the patient is improving or not. So, and all other than the escalation, de-escalation is also very important. And when you have treated the patient well, if you have got him out of the danger, and if you you see that the patient is getting better on the right trajectory, that is the time that you should de-escalate your antibiotics. Sometimes we are really good at escalating. We quickly escalate to meropenem when the patient is getting worse, but the patient is getting better, you don't de-escalate antibiotics. That is a different topic. Like sometimes, even without the cultures, you can do clinical de-escalation by rationally thinking what can be the organism, and what is the antibiotic that you can de-escalate into. So it's a basically different topic basically. So maybe we can discuss on it in a later date. But of course, clinical plus investigation decide on escalation and de-escalation.
Okay. Right. Thank you very much. I think uh, we can wind up the session now. I think we may not have any more questions. And yes, so thank you very much, Professor Lakmal Fonseka. On behalf of the Sri Lanka College of Internal Medicine, I extend my sincere gratitude to you for sharing your knowledge and insights. Thank you so much, dear sir. And I also thank the President and the Council of the Sri Lanka College of Internal Medicine for their guidance and support to continue the Next Gen Forum, which will give novel insights through the next generation of physicians. And I'm truly grateful to all participants who have joined despite the technical issues we had to face in the beginning. We had a massive participation of nearly 250 participants. Thank you so much for your enthusiasm and the interest in this topic. So you will be the future uh, uh, stewards of antibiotic prescription. So with that, I would like to conclude today's session. and thanking Professor Lakmal Fonseka for joining us today for this excellent presentation with meaningful insights. Thank you so much. I wish you all a very good night.